Walking compared with vigorous physical activity and risk of type 2 diabetes in women. Prospective study. This is a peer-reviewed article that uses epidemiological methods to examine a health-related issue by Yu et al. Type 2 diabetes is a widespread and serious health problem around the world, often caused by lifestyle choices like not getting enough exercise and being overweight. Since many adults struggle to keep up with intense workouts, it is important to find out if easier, moderate activities like walking can also lower the risk of diabetes. If walking is as effective as vigorous exercise, public health advice could focus on the simple change that most people can manage, which might help prevent many new cases of diabetes. The objective is to determine how overall physical activity relates to the risk of developing type 2 diabetes in women, and to assess whether walking offers protection comparable to vigorous exercise in predicting future diabetes risk. The authors aim to generalize their findings to middle-aged and older women in the United States who do not have major chronic diseases at the start of the study. This group is similar to the 70,102 female nurses aged 40 to 65 years who were recruited from 11 U.S. states. In a prospective cohort study, researchers measure the exposure at the start when participants do not yet have the outcome. For example, they record physical activity levels in women who do not have type 2 diabetes. These participants are then followed over time to see who develops diabetes and when. Since activity is recorded before any new cases appear, this design indicates that exposure precedes disease, which is important for understanding causation. Tracking the cohort over time also allows researchers to calculate incidence, new cases per person time, and estimate relative risk or hazard ratios by comparing disease rates in more active and less active groups. The study involved 70,102 female nurses aged 40 to 65 who did not have diabetes, cardiovascular disease, or cancer at baseline. Rather than focusing on formal power or sample size calculation, the article uses data from the large Nurses' Health Study cohort. The study sample came from the Nurses' Health Study cohort. This group was first recruited by sending questionnaires on medical history and health behaviors to registered nurses aged 30 to 55 in 11 U.S. states. Those who responded were enrolled in the study. Inclusion criteria. The study included female registered nurses aged 40 to 65 years who live in one of the 11 U.S. states, completed the physical activity questionnaire, and did not have diagnosed diabetes, cardiovascular disease, or cancer at baseline, except for non-melanoma skin cancer. Women who later developed type 2 diabetes and met the strict diagnosis criteria were considered new cases. Exclusion criteria. Women were not included if they had diabetes, cardiovascular disease, or cancer at the start of the study, or if they did not have complete physical activity data. In this observational study, there is no separate randomized control group. Instead, the authors use the women with the lowest physical activity as the reference group. This means they compare women with the least total activity to those with higher activity levels to see how diabetes risk changes. At the start, the more active women tended to be leaner or lower BMI and were less likely to smoke or have high blood pressure than the least active women, but their intake of dietary fat and cholesterol was about the same. This starting difference matter because they can affect the link between activity and diabetes. Healthier women might have a lower risk partly because of their weight, smoking habits, or blood pressure, not just their activity level. To address this, the authors use models that adjust for BMI, smoking, high blood pressure, and other factors. This helps ensure that comparisons between activity groups focus more on the effect of physical activity itself on diabetes risk. First, the researchers calculated the incidence rate and age-adjusted relative risk of type 2 diabetes for different levels of physical activity, measured in quantiles using person years. Next, they used pooled logistic regression to estimate relative risk adjusted for several factors, including age, smoking, alcohol use, menopausal status, hormone therapy, parental history of diabetes, hypertension, hypercholesterolemia, and later BMI. They also tested for linear trends in physical activity levels as MET values increased. Univariate results showed that before taking BMI, the other factors into account, women who were most physically active had about half the risk of type 2 diabetes compared to those who were least active. Women who walk the most, even if they did not do vigorous exercise, also had much lower risk. Multivariate results showed that after adjusting for age, smoking, alcohol use, menopausal status, parental diabetes, hypertension, hypercholesterolemia, and BMI, higher total physical activity and more walking still predicted a lower risk of type 2 diabetes. However, the association was weaker, indicating that some, but not all, of the benefits of activity stem from differences in body weight. The authors concluded that women who are more physically active have a substantially lower risk of developing type 2 diabetes, and that moderate intensity activity such as brisk walking can reduce risk to a degree comparable to vigorous exercise when total energy expenditures is comparable. Their findings support the idea that everyday walking, if done at sufficient intensity and duration, is an effective and accessible strategy for diabetes prevention in middle-aged and older women. I agree with the authors that being more physically active lowers the risk of type 2 diabetes, and that brisk walking can be as effective as vigorous exercise if the total energy use is similar. Although the study is older, it is still often cited and taught because its results are aligned with newer research, and it highlights walking a simple and realistic activity for most people. From a public health point of view, walking daily is much easier to maintain than doing intense workouts once or twice a week, which is harder to sustain and require more recovery time. This focus on walking makes the study both scientifically sound and very useful for creating long-term prevention plans that people are more likely to follow. This study may be affected by self-reported physical activity or informational bias, a mostly similar nurse population which limits generalizability and potential confounding by other healthy behaviors. Self-reports probably understate a true protective effect of activity, making differences between groups less clear. At the same time, healthy user effects and incomplete control of confounders could make the risk reduction from walking and vigorous exercises appear larger than it really is. These biases do not change the main finding that higher activity is beneficial, but they suggest that the exact size of the effect should be viewed with caution. The authors did not fully consider several important factors such as detailed dietary patterns, psychosocial stress, sleep, and environmental context. This could have influenced both physical activity and diabetes risk. These findings are applicable to middle-aged and older U.S. women with similar characteristics to the nurses in the cohort, but may not fully generalize to men, younger individuals, or women from different socioeconomic and ethnic backgrounds, because the study population are all women and health aware. To test this hypothesis, the best approach would be a long-term randomized controlled trial. Women at risk for type 2 diabetes would be randomly placed into different exercise groups, such as brisk walking, vigorous exercise, or a control group that maintains usual activity. Each exercise group would have similar weekly energy goal and would be monitored with objective tools like accelerometers. Researchers would then track participants over several years to see who developed type 2 diabetes. This concludes my presentation.